A number of pleural diseases can cause fluid to accumulate in the pleural space. This fluid is called a pleural effusion, or if infected, an empyema. Similar to free air in the pleural space, fluid accumulation separates the viscera and parietal pleura and compresses the lungs. In severe cases, atelectasis will develop, the great veins may be compressed, and cardiac venous return may be diminished. Pleural effusion and empyema produce a restrictive lung disorder. Approximately 0.26 mL of fluid per kilogram of body weight is estimated to be contained in each pleural cavity. It is produced and absorbed primarily on the parietal surface, which is the chest wall. Under normal circumstances, the amount of fluid in the pleural space depends on the balance of hydrostatic and oncotic pressures between the parietal and visceral pleura and the pleural space. Fluid in the pleural space is primarily produced from the parietal pleura because the hydrostatic pressures are higher on the parietal pleura than on the visceral pleura, and the oncotic pressures are equal. Hydrostatic pressure is a function of arterial circulation. The oncotic pressures reflect largely the protein concentration in the blood and lymphatic vessels. The lymphatic vessels in the parietal pleura, which is your chest wall, are responsible for fluid reabsorption. They have a tremendous capability, up to 20-fold, to respond to increased pleural fluid formation. Pleural effusion affects more than 1.5 million people each year in the United States. Congestive heart failure, cancer, and pneumonia account for the majority of the cases. Early signs and symptoms include pleuritic chest pain, chest pressure, dyspnea, and cough. Chest pain can occur early when there is intense inflammation of the pleural surfaces. Chest pressure does not usually develop until the effusion reaches the moderate category, which is 500 to 1500 mLs, or to the large category, which is more than 1500 mLs. Dyspnea rarely occurs in small effusions unless significant pleurisy is present. A cough is usually directly related to the degree of atelectasis caused by the effusion. A pleural effusion can be classified in the following manners: by the origin of the fluid, that is, for example, serous fluid, which would be known as a hydrothorax. If there was blood present, then it would be called a hemothorax. If there's a presence of chyle, then it would be called a chylothorax. If there is pus, it would be called a pylothorax or an empyema. And if urine is present, then it would be called a urinothorax. The other way that it can be classified is by the pathophysiology of the pleural effusion, that is, either transudated pleural effusion or an exudated pleural effusion. A transudate develops when fluid from the pulmonary capillaries move into the pleural space. The fluid is thin and watery, containing few blood cells and little protein. The pleural surfaces are not involved in producing the transudate. In contrast to a transudate, an exudate develops when the pleural surfaces are diseased. The fluid has a high protein content and a great deal of cellular debris. Exudate is usually caused by inflammation, infection, or malignancy. This table shows the criteria for differential diagnosis of transudate and exudates that largely rely upon the light criteria. Careful, systematic analysis of pleural fluid will reveal the diagnosis as one or the other in about 75% of the patients and give good evidence of its causes, and with microscopic examination for abnormal cell types. Congested heart failure is the most common cause of pleural effusion. Both right and left-sided heart failure can result in pleural effusion. In general, left-sided heart failure is more likely to produce pleural effusion than right-sided heart failure. In left-sided heart failure, an increase in hydrostatic pressure in the pulmonary circulation can decrease the rate of pleural fluid absorption through the visceral pleura and cause fluid movement through the visceral pleura into the pleural space. In right-sided heart failure or cor pulmonale, an increase in hydrostatic pressure in the systemic circulation can increase the rate of pleural fluid formation and decrease lymphatic drainage from the pleural space because of the elevated systemic venous pressure. Hepatic hydrothorax is defined as a pleural effusion usually greater than 500 mL in the patient with cirrhosis, particularly with ascites fluid is present in the abdomen and without primary cardiac, pulmonary, and pleural disease. It develops most likely because of diaphragmatic defects that have been opened by increased peritoneal pressure, thus allowing the passage of fluid from the peritoneal space to the pleural space. Hepatic hydrothorax may be difficult to manage in end-stage liver failure and often fails to respond to therapy. Because of the location of the liver, the pleural effusion in these patients is generally right-sided. Peritoneal dialysis, as in the pleural effusion that occurs as a result of abdominal ascites. On rare occasion, a pleural effusion may develop as a complication of peritoneal dialysis in the treatment of severe chronic kidney disease. Peritoneal dialysis uses the patient's peritoneum in the abdomen as a membrane across which fluids and dissolved substances such as electrolytes, urea, glucose, albumin, and other small molecules are exchanged with the blood. When the peritoneal dialysis is stopped, the pleural effusion usually disappears rapidly. Parapneumatic pleural effusions. Effusions that occur as a result of underlying pulmonary infection are termed parapneumatic effusions. For example, those following a pneumococcal or staphylococcal pneumonia abutting up to the visceral pleural surface. In patients with this type of effusion, it may be necessary to perform an invasive procedure for the diagnosis as opposed to a simple thoracentesis. This is true when effusions occupies more than 50% of the hemothorax and presents as a loculated pleural effusion, or the fluid shows a positive Gram stain or culture, and the purulent pleural fluid shows a pH of less than 7.20 or a glucose value greater than 60 milligrams per deciliter. If a needle thoracentesis is not successful in removing the fluid, a chest tube should be inserted, perhaps with the use of video-assisted thoracic surgery, which is a VATS. After this, consideration of use of intrapleural fibrinolytics may be considered. Failing that, a full thoracotomy or decortation, so-called pleural peel, may be needed to be performed, and or an open drainage of the parapneumonic effusion may be required. Nephrotic syndrome. Pleural effusion is commonly seen in patients with nephrotic syndrome. It is generally bilateral. The effusion is a result of a decreased plasma oncotic pressure that develops in patients with this disorder. Pulmonary embolism or infarction. Between 30 and 50% of the patients with pulmonary artery emboli develop pleural effusion. Two distinct mechanisms are responsible. First, obstruction of the pulmonary vasculature can lead to right-sided heart failure, which in turn can lead to pleural effusion. Second, increased permeability of the capillaries. Pulmonary infarction in the visceral pleural develops in response to the ischemic infarction caused by the pulmonary emboli. Common causes of exudated pleural effusion. Empyema. The accumulation of pus in the pleural cavity is called an empyema. Empyema commonly develops as a result of inflammation. Thoracentesis may confirm the diagnosis and determine the specific causative organism. The pus is usually removed by thoracostomy tube drainage. Open thoracotomy drainage may occasionally be necessary. Malignant pleural effusions. About 2/3 of malignant pleural effusions occur in women. Malignant pleural effusions are highly associated with breast cancer. The pleural effusion is usually caused by a disturbance of the normal Starling forces regulating reabsorption of fluid in the pleural space, secondary to obstruction of the mediastinal lymph nodes draining the parietal pleura. Tumors that metastasize frequently to these nodules, for example, lung cancer, breast cancer, and lymphomas, cause more malignant effusions. Malignant mesothelioma arises from the mesothelial cells that line the pleural cavities. Individuals who have had chronic exposure to asbestos have a much greater risk of developing mesothelioma. Pleural fluid is inexudative and generally contains a mixture of normal mesothelial cells, differentiated and undifferentiated malignant mesothelial cells, and varying number of lymphocytes and polymononuclear leukocytes. Bacterial pneumonias. Up to 40% of the patients with bacterial pneumonia have an accompanied pleural effusion. Most pleural effusions associated with pneumonia resolve without any specific therapy. Approximately 10%, however, require some sort of therapeutic intervention. If appropriate antibiotic therapy is not instituted, bacteria invade the pleural fluid from the lung parenchyma. Eventually, pus will accumulate in the pleural cavity, which is an empyema. Pleural effusion also can be produced by viruses, Mycoplasma pneumoniae, and Rickettsia, although the pleural effusions are usually small. Tuberculosis. Pleural effusions may develop from extension of the caseous tubercle into the pleural cavity. It also is possible that the inflammatory reaction that develops in tuberculosis obstructs the lymphatic pores in the parietal pleura. This in turn leads to an accumulation of protein and fluid in the pleural space. Pleural effusions caused by tuberculosis is usually unilateral and small to moderate in size. Fungal diseases. Patients with fungal diseases occasionally have secondary pleural effusions. Common fungal diseases that may produce pleural effusions are histoplasmosis, coccidioidomycosis, and plastomycosis. Pleural effusions resulting from diseases of the gastrointestinal tract. Pleural effusion is sometimes associated with diseases of the gastrointestinal tract, such as pancreatitis, subphrenic abscesses, intrahepatic abscesses, esophageal proliferation, abdominal operations, and diaphragmatic hernias. Pleural effusions resulting from collagen vascular disease. Pleural effusions occasionally develops as a complication of collagen vascular disease. Such diseases include rheumatoid pleuritis, systemic lupus erythematosus, Sjogren's syndrome, familial Mediterranean fever, and Wegener's granulomatous. Other pathological fluids that separate the parietal from the visceral pleura. In addition to transudates and exudates, other pathological fluids can separate the parietal pleura from the visceral pleura. Chylothorax. Chylothorax is the presence of chyle in the pleural cavity. Chyle is a milky liquid produced from the food in the small intestine during digestion. It consists mainly of fat particles in a stable emulsion. Chyle normally is taken up by finger-like intestinal lymphatics called lacteals and transported by the thoracic duct to the neck. From the thoracic duct, the chyle moves into the venous circulation and mixes with blood. The presence of chyle in the pleural cavity is usually caused by trauma to the neck or thorax or by cancer occluding the thoracic duct. Hemothorax. The presence of blood in the pleural space is known as a hemothorax. Most of these are caused by penetrating or blunt chest trauma. An iatrogenic hemothorax may develop from trauma caused by the insertion of a central venous or pulmonary artery catheter. Blood can gain entrance into the pleural space from trauma to the chest wall, diaphragm, lung, or mediastinum. A hematocrit of the pleural fluid always should be obtained if the pleural fluid looks like blood. A hemothorax is said to be present only when the hematocrit of the pleural fluid is at least 50%. The following clinical manifestations result from the pathological mechanism caused or activated by atelectasis, the major anatomical alterations of the lungs associated with pleural effusion. The physical examination. Vital signs show increased respiratory rate. Several pathological mechanisms operating simultaneously may lead to this increase in ventilatory rate. Stimulation of the peripheral chemoreceptors from hypoxemia. Relationship of decreased lung compliance as a result increasing the ventilatory rate. Activation of the deflation receptors. Activation of irritant receptors. Stimulation of J receptors. Pain, anxiety, increase in heart rate, pulse, and blood pressure. Chest pain, which is often pleuritic. Decreased chest expansion is noted. The presence of cyanosis. And cough that is dry and non-productive. On physical examination, chest assessment findings. Palpation. Tracheal shift away from the affected side may be noted. On palpation, decreased tactile and focal firmness. During percussion, dull percussive note may be noted. On auscultation, diminished breath sounds, displaced heart sounds, and pleural friction rub may occasionally be present. Respiratory mechanics will show a tidal volume that may be normal or decreased, and expiratory reserve volume may be decreased. Reserve volume also may be decreased. Vital capacity is decreased. Inspiratory capacity will be decreased, FRC will be decreased, TLC will be decreased, but your RV to TLC ratio would be normal. The diagnosis of a pleural effusion is generally based on the chest radiograph. A pleural effusion of less than 300 mLs usually cannot be seen on a chest radiograph in an upright patient. In a moderate pleural effusion, such as greater than 1,000 mLs, in the upright position, an increased density usually appears at the costophrenic angle. The fluid first accumulates posteriorly in the most dependent part of the thoracic cavity between the inferior surface of the lower lobe and the diaphragm. As the fluid volume increases, it extends upward around the anterior, lateral, and posterior thoracic walls in the meniscus sign. Interlobular fissures are sometimes highlighted as a result of the fluid filling. In the upright chest radiograph of a pleural effusion, the lateral costophrenic angle is usually obliterated and the outline of the diaphragm on the affected side is lost. In severe cases, the weight of the fluid may cause the diaphragm to become inverted or concave. Clinically, this inversion is seen only in left-sided pleural effusions. The gastric air bubble is pushed downward and the superior border of the left diaphragmatic leaf is concave. In addition, the mediastinum may be shifted to the unaffected side and the intercostal space may appear widened. Pleural effusion, atelectasis, and parenchymal infiltrates can obliterate one or both diaphragms. Therefore, when the posterior, anterior, or lateral chest radiograph suggests a pleural effusion, additional radiographic studies are generally necessary to document the presence of pleural fluid or other pathology. The lateral decubitus radiograph is recommended because free fluid gravitates to the most dependent part of the pleural space and the layers out there. General management of pleural effusion. The management of each patient with a pleural effusion must be individualized. Questions to be asked include the following. Should a thoracentesis be performed? Can the underlying cause be treated? What is the appropriate antibiotic? Should a chest tube be inserted? When it is determined that a chest tube should be inserted, it is normally placed in the fourth or fifth intercostal space at the mid-axillary line. Typically, a number 28 to 36 French thoracostomy tube is used for adults, with a smaller size for children. A pigtail catheter may be used in draining fluids or air from pleural spaces. The best way to resolve a pleural effusion is to direct the treatment at what is causing it, rather than treating the effusion itself. For example, if the heart failure is reversed or the lung infection is cured by antibiotics, the effusion usually resolves. When the cause of the pleural effusion is not readily evident, microscopic and chemical examination of the pleural fluid may determine whether the effusion is a transudate or an exudate. If the fluid is a transudate, treatment is directed to the underlying problem, for example, such as congested heart failure, cirrhosis, or nephrosis. When the exudate is present, a cytological examination may identify a malignancy. The fluid must be examined for its biochemical makeup, in other words, for proteins, sugars, and various enzymes, and from the presence of bacteria. Examination of the effusion may reveal blood after trauma or surgery, pus in empyema, or a milky fluid in chylothorax. The presence of blood in the pleural fluid in the absence of trauma or surgery suggests malignant disease, pulmonary embolization, or infarction. Respiratory care treatment protocols. Oxygen therapy protocol. Oxygen therapy is used to treat hypoxemia, decrease work of breathing, and decrease myocardial work. The hypoxemia that develops in pleural effusion is most likely caused by atelectasis and pulmonary shunting associated with the disorder. Hypoxemia is caused by capillary shunting is often refractory to oxygen therapy. Lung expansion therapy protocol. Lung expansion techniques are often administered to offset the atelectasis associated with pleural effusions and are particularly helpful once the pleural fluid has been removed by thoracentesis or thoracostomy. Mechanical ventilation protocol. Because acute ventilatory failure and hypoxemia may be seen in severe pleural effusions, continuous mechanical ventilation may be required to maintain an adequate ventilatory status. Continuous mechanical ventilation is justified when acute ventilatory failure is thought to be reversible. Pleurodesis. A pleurodesis may be performed to cause irritation and inflammation, a pleuritis, between the parietal and visceral layers of the pleura. During pleurodesis, a sclerosant is injected into the chest cavity, such as talc or tetracycline or bleomycin sulfate. The chemical substance or medication causes an intense inflammatory reaction over the outer surfaces of the lung and inside the chest cavity. This procedure is performed to cause the surface of the lung to adhere to the chest wall, thus preventing or reducing recurrent pneumothorax or recurrent pleural effusion. Intense pleuritis is produced, which may be quite painful.